whenever a patient with primary amenorrhea who has got normal breast development comes to you, if a patient has primary amenorrhea plus normal breast development, then first of all you should you should rule out cryptomenorrhea. Once cryptomenorrhea is ruled out, then you should get an ultrasound done. In ultrasound, you should see whether uterus is present or absent. Now, if in ultrasound uterus is absent, then there can be only two problems. Either it could be a Mayer-Rokitansky-Kuser-Hauser syndrome, or it could be androgen insensitivity syndrome. Now, in order to come to a definitive diagnosis, the investigation of choice is karyotyping. Because as we know, in MRKH syndrome, the genotype or karyotype is 46XX, whereas in androgen insensitivity syndrome, it is 46XY. Or also you can look for the presence of Barr body. In case of MRKH syndrome, where the chromosome number is 46XX, one Barr body is present, whereas in case of androgen insensitivity syndrome, where the chromosome number is 46XY, there will be no Barr body. So this is all what we should know on MRKH syndrome and testicular feminization syndrome. Coming to compartment 2. In compartment 2, the most important cause is Turner syndrome. I have already told you Turner syndrome is also the most common cause of primary amenorrhea. It is also the most common cause for delayed puberty in females. Now, in Turner's syndrome, the chromosome number is 45X0. Because chromosome number is 45X0 and because there is no Y chromosome, so obviously the gonads will not be testes, but then they do not also have two X chromosomes. Two X chromosomes are responsible for formation of ovaries. Now here there is a single X chromosome. That is why the ovaries are not well developed in these patients and they have got what is called as streak gonads. Now, because their gonads are streak, their ovaries are not very well developed. So, the level of estrogen in these patients will also be less. And because they have inadequate estrogen, what will happen to the secondary sexual characteristics? Secondary sexual characteristics will not be developed. And estrogen, it is also responsible for increase in height. Because there is less of estrogen, these patients will be short-statured. And because they have less estrogen, the uterus, fallopian tubes and vagina, they will also be infantile. So they will have infantile or hypoplastic uterus and vagina. This is the reason why they have amenorrhea. Besides this, you know that in Turner syndrome, many other physical characteristics are seen. Like in Turner syndrome, there is webbing of neck. They have clubbing, cubitus valgus deformity, shield-shaped chest, Madelung deformity of the vertebra. But this is something which you study in your pathology in medicine. I am not concerned with all the characteristics of Turner syndrome. I am concerned with what is the gynecological aspect of Turner syndrome. So these patients will come to a gynecologist with a complaint of primary amenorrhea. Now, how can we help them? The management. Management in these patients is, because the problem in these patients is less estrogen, So we will give them estrogen replacement therapy. In an intact uterus, estrogen can lead to endometrial hyperplasia. So to protect against endometrial hyperplasia, you will add progesterones. And because these females, they are short statured, we will have to add growth hormone. This is how we manage Turner syndrome. Another thing which we should remember here is that in X chromosomes, the gene which protect against the physical malformations of Turner, they are present on the short arm of X chromosomes, whereas the genes which protect against streak gonads, they are present on the long arm of X chromosome. Therefore, if in a patient the short arm of X chromosome is absent, be it XX, 46XX, or be it 46XY, if the short arm of X chromosome is absent, the genes which are protecting against the physical malformation of Turner syndrome will be absent, and so these patients, although they will not have streak gonads, they will have physical malformations of Turner syndrome, either in male or in female direction. Whereas on the other hand, if the long arm of X chromosome is absent, the genes which are protecting against streak gonads are absent. So if the chromosome number is 46XX but the long arm of X chromosomes is absent, it will lead to streak gonads also, although the physical manifestations of Turner syndrome will not be there. This is exactly what is happening in true gonadal dysgenesis, the second cause of primary amenorrhea in compartment 2. In true gonadal dysgenesis, the gonads are streak, but the physical malformations of Turner syndrome is absent. The third cause in second compartment was Sewers syndrome, SWYERS syndrome. There I have told you it is 46XY, and there the problem is that it is the male counterpart of Turner's syndrome. The fourth was Savage syndrome. Savage syndrome means resistant ovary syndrome. This means although the ovary is normal, although the levels of estrogen are normal, but ovary is resistant to estrogen, and that is the leading to primary amenorrhea. We don't have to know details of Sewers syndrome or Savage syndrome, till yet they have never been asked. Then coming to compartment 3, in compartment 3 I told you in the cause for primary amenorrhea in compartment 3 is craniopharyngioma, the details of which you will do in pediatrics. Coming to compartment 4, in compartment 4 the causes were Kalaman syndrome. Now Kalaman syndrome, it is a condition in which there is hypothalamic dysfunction, there is decreased hypothalamic function plus olfactory problem, that is anosmia. That is Kalaman syndrome. This is all what we have to remember, that there is decreased hypothalamic function plus anosmia, which is seen in case of Kalaman syndrome. Kalaman syndrome, it can occur in males as well as it can occur in females. And next was Lawrence-Moon-Bedell syndrome. Again in Lawrence-Moon-Bedell syndrome, their problem is that there is less of GnRH secretion, there is decreased GnRH, which will lead to amenorrhea, plus there will be obesity, mental retardation, polydactyly, and retinitis pigmentosa. That is all what we have to know in case of primary amenorrhea. Now coming to secondary amenorrhea. Now secondary amenorrhea, it is a condition in which there is absence of menstruation for 3 menstrual cycles. That means the female was earlier menstruating normally, but for the past 3 cycles she is not menstruating, or there has been absence of menstruation for 6 months in a previously menstruating female. That is secondary amenorrhea. The most common cause of secondary amenorrhea is pregnancy, and therefore whenever a patient with secondary amenorrhea comes to you, you should always rule out pregnancy. Coming to the causes of secondary amenorrhea, again we are going to do it compartment wise. In compartment 1, that is the problem which is related to uterus, the most common cause or the most important cause which we need to know is Asherman syndrome. Other cause could be acquired obstruction of the tract, like it occurs in the case of cauterization of cervix, conization of cervix, amputation of cervix when you do in Fothergill's operation. In compartment 2, the most important cause which we need to know is polycystic ovarian disease, the details of which I'll be doing right now. That is Steen-Leventhal syndrome, or it could be ovarian tumors, or it could be surgical removal of the ovaries, radiotherapy, or infections of the ovary like tuberculosis. Coming to compartment 3, in compartment 3, that means causes which are related to pituitary. The cause could be number 1, pituitary tumors like adenomas. It could be Sheehan syndrome. Then it could be hyperprolactinemia. These are some of the important causes which can occur in pituitary, which can lead to secondary amenorrhea. Compartment 4, that is hypothalamus. The cause of secondary amenorrhea could be excessive weight loss, excessive exercise, emotional stress, then anorexia nervosa, bulimia. In all these conditions, the release of GnRH is affected, and that is why it leads to secondary amenorrhea. Besides these compartment-wise causes, other generalized systemic causes of secondary amenorrhea are hypothyroidism, diabetes, chronic liver disease, renal disease, anemia, HIV. Now, coming to compartment 1. In compartment 1, I told you the most important cause which we have to remember is Asherman syndrome. Now, what is Asherman syndrome? Asherman syndrome, it is a condition in which the endometrial lining of the uterus is destroyed, and this results in formation of intrauterine synechia. In the uterus, number of synechia will be formed, and that is what is Asherman syndrome. The most common cause of Asherman syndrome is a curettage, which is done after delivery, postpartum curettage, that is the most common cause. Other causes of Asherman syndrome are tuberculosis, schistosomiasis and endometrial ablation. Next question which they ask on Asherman syndrome is like, how is an Asherman syndrome patient going to present to you? Because the endometrial lining is destroyed, that is why she'll be complaining of amenorrhea, or she could also complain of hypomenorrhea. What is hypomenorrhea? Hypomenorrhea is when normally a female menstruates, the menstrual days are 2 to 5 days. Now if the bleeding is for less than 2 days, that is called as hypomenorrhea. So the female can either complain of amenorrhea or she can complain of hypomenorrhea, and besides this there will be infertility in case of Asherman syndrome. The investigation of choice for Asherman syndrome, if this is the uterus, these are the synechia. Now if we want to visualize these synechia, there are two methods by which we can visualize these synechia. Number one is hysteroscopy. That means you introduce an endoscope inside the uterus and you visualize the synechia directly. That is hysteroscopy. Hysteroscopy is the investigation of choice because besides being diagnostic, it is therapeutic. At the same time, during hysteroscopy, you can also cut the adhesions. That means you can do hysteroscopic adhesiolysis. And the second investigation is hysterosalpingography. That means you introduce a dye inside, a radio opaque dye inside the uterus, and then you see with the help of an X-ray that these synechia will be evident and they give the appearance of a honeycomb. But hysterosalpingography, it is not the investigation of choice. The reason being that hysterosalpingography is only diagnostic and not therapeutic. How do you manage Asherman syndrome? Management of Asherman syndrome is hysteroscopic adhesiolysis of these hysteroscopic adhesiolysis followed by IUCD insertion. That is all what we need to know in case of Asherman syndrome. In compartment 2, the most important cause is polycystic ovarian disease. Now, what is polycystic ovarian disease? This is a very common problem in our OPDs, and these days many questions are also being asked on polycystic ovarian disease, so it becomes a very important topic for PGME. I'm going to cover PCOD in detail. The other name for polycystic ovarian disease is Steen-Leventhal syndrome. Now, the problem in case of PCOD is that there is excessive androgen production. This androgen production is basically, generally it is from the ovary, and that is why it is the free testosterone which is more produced, although other androgens like dehydroepiandrosterone sulfate, DHEA sulfate and androstenedione are also produced, but the main is testosterone. Now, because there is excessive androgen production in a female body, what will happen? Number one, this excessive androgen is going to lead to excessive hair growth in male hair growth pattern. There will be excessive hair growth, that is called as hirsutism. The most common cause of hirsutism in a young female, in a female who is between 15 to 25 years of age, is polycystic ovarian disease. That is the first question. But if the question says what is the most common cause of rapid onset hirsutism, then for rapid onset hirsutism it is not PCOD. Rapid onset hirsutism means there is some testosterone secreting tumor of the ovary. So this is the difference between these two questions. Now, excessive androgen production on one hand is going to lead to excessive hair growth or hirsutism. Other features of male, like other features of virilization, like clitoromegaly, deepening of voice, alopecia, they are very rare. Although alopecia, clitoromegaly, deepening of voice can occur, but then they are rare. The main feature is hirsutism. Then these androgens in the female body, they will get converted into estrogens. Androgens, they are peripherally converted into estrogens. So this means there will be excessive estrogen in the female body. Now, because there will be excessive estrogen, what will be the problem? The long-term sequelae will be excessive estrogen can lead to endometrial hyperplasia. So later on, in long-term consequences, there can be endometrial hyperplasia or endometrial cancer. That is one problem. Other problem is that in a normal menstrual cycle, you know that estrogen, it has got a negative feedback on follicle stimulating hormone. Now, if there is excessive estrogen, there will be excessive downregulation of FSH. So the levels of FSH will be decreased. Whereas estrogen, it has got a positive feedback on luteinizing hormone. So what will happen to this luteinizing hormone? The levels of luteinizing hormone are increased in patients of PCOD. Now, the normal FSH is to LH ratio is 2:1. But in a case of PCOD, FSH levels are decreased and LH levels are increased. So this ratio becomes 1:2, 1:3, 1:4, etc. So if you are testing the levels of LH and FSH, you can come to make the diagnosis of PCOD. The question which they ask here is that when you are doing LH and FSH, the sample for LH and FSH for the diagnosis of PCOD should be withdrawn on the 2nd or the 3rd day of menstrual cycle. That is a very important question. Now, in a normal menstrual cycle, what is the cause for ovulation? The cause for ovulation in a normal menstrual cycle is the LH surge. What happens is, in a normal menstrual cycle, when estrogen, it has a positive feedback on LH, so the levels of LH, they increase, and they suddenly increase, and there is an LH surge. It is this LH surge which leads to ovulation. Here they ask you one question, and that is, ovulation occurs after how many hours of LH surge? After 32 to 36 hours of LH surge, ovulation occurs. If LH surge is absent, there will be an ovulation. Now, what happens in patients of PCOD? In patients of PCOD, this LH is constantly raised. There is tonically elevated LH. There is no LH surge, because LH is constantly raised, and because there is no LH surge, it leads to an ovulation. So there is an ovulation. Number 2 problem is, in a normal menstrual cycle, it is luteinizing hormone which acts on the theca cells to produce androgens. Now, because there is excessive luteinizing hormone, there will be theca cell hypertrophy. And this theca cell hypertrophy, there will be excessive androgen production. That means it is a vicious cycle. The problem started with excessive androgen production, and again there is excessive androgen production. So PCOD, it is characterized by excessive androgen production and an ovulation. Now, Another problem. Here I told you, because there is excessive androgen production, I told you the levels of estrogen are increased. Another problem due to excessive androgen production is that there is atrophy of the endometrium. Because there is atrophy of the endometrium, patient will complain of oligomenorrhea or amenorrhea. And number 3, because of excessive androgen production, there will be dyslipidemia. That means the levels of triglycerides and VLDL, they increase, whereas the levels of HDL decrease. So what happens? Because of this dyslipidemia, in future it can lead to heart disease. So the future problems in case of PCOD, number 1, I told you here, in future patients of PCOD can have endometrial hyperplasia or endometrial cancers. And number 2, these patients are prone to coronary vascular disease. Because of an ovulation, what will happen? Because of an ovulation, if there is no ovulation, there will be very less progesterone. So the levels of progesterone in these females are decreased. That is another reason for oligomenorrhea or amenorrhea. And number 2, what happens to, if there is no ovulation, what happens to the Graafian follicles in these females? These follicles, they are converted into cysts. This is the reason why there are multiple cysts in both the ovaries in case of PCOD, and this is the reason why it is called as polycystic ovarian disease. And these cysts, they are arranged around the periphery of the ovary, giving it a necklace appearance. The third problem due to anovulation is that this female is going to complain of infertility. Now, besides these problems, there are other problems which are there in PCOD. Number 1, there is obesity in these females. These females are very obese. Number 2, there is insulin resistance. Because of insulin resistance, there is hyperinsulinemia, and this can lead to 2 problems. Number 1 is acanthosis nigricans, which is seen in 5% cases. In case of acanthosis nigricans, there is a dark pigmentation which occurs in axilla, which occurs in the nape of neck, and which occurs below the breasts. This is called as acanthosis nigricans, and this hyperinsulinemia in due course of time, it can also lead to diabetes. So diabetes is another long-term consequence of polycystic ovarian disease. There is another thing which is called as hair-end syndrome. Hair-end syndrome is a feature of polycystic ovarian disease. Hair-end syndrome means HA stands for hyperandrogenism, IR stands for insulin resistance, and AN stands for acanthosis nigricans. So hair-end syndrome is seen in a few patients in case of PCOD. The questions which they ask on PCOD is, number 1, what is the most common age group for PCOD? The most common age group for PCOD is 15 to 25 years of age. Number 2, what are the consequences, the chronic consequences of, or the long-term consequences of chronic anovulation? Now, chronic anovulation is occurring in the case of PCOD. So what are the long-term consequences of PCOD? We've just discussed them. Number 1, heart disease. Number 2, endometrial hyperplasia or endometrial cancer. And number 3, diabetes. Number 4, metabolic X syndrome. Infertility in case of PCOD is very easily treatable because it is a result of an ovulation. You just have to give ovulation inducing drugs and the infertility is treated. So infertility is not a long-term consequence. Rather, if they ask you what is the most common cause for easily treatable infertility, PCOD is one of those causes. Now, how do we manage a patient of PCOD? Before managing, how do you diagnose a patient of PCOD? For the diagnosis of PCOD, there has been a criteria which was given in Rotterdam 2003, which says any 2 of the following criteria should be fulfilled in case to classify a patient as that of PCOD. Number 1, there should be an ovulation. Oblique ovulatory dysfunction, which can be evident by oligomenorrhea or amenorrhea. Number 2 criteria is physical or biochemical indication of increased androgens. And number 3 is ultrasound diagnosis of PCOD. So out of these 3 criteria, if any 2 criteria are being fulfilled, we classify the patient as that of PCOD. Now, what is the ultrasound criteria for PCOD? Ultrasound criteria for PCOD is, number 1, there should be multiple cysts in the ovary, in both the ovaries, more than 12 in number, and the size of the cysts should be roughly between 8 to 10 millimeters. Number 2, these cysts, as I told you, they are generally arranged in around the periphery of the ovary, giving it a necklace appearance. Number 2 is dense echogenic stroma of the ovary. And number 3, increase in the volume of the ovary, that is, it should be more than 10 cc. So these are the ultrasonographic criteria for PCOD. Besides this, in PCOD, you can diagnose PCOD by getting FSH and LH ratio done on day 2 or day 3 of the cycle. Coming to the management of PCOD. Now, for management of PCOD, first we will have to see the problem. Whatever is the problem, as per the problem we are going to manage. For example, if the chief complaint of the patient is obesity, then you are going, and what is obesity? Obesity is defined as BMI more than 29 kgs per meter square. For obesity, we will advise lifestyle modification in diet as well as exercises, moderate exercises. With weight loss, there will be resumption of menses, and it will also reduce the androgen levels. If the patient is coming to us with infertility, now infertility in case of PCOD is due to anovulation, so here we are going to advise ovulation inducing drugs like clomiphene, citrate, letrozole or GnRH. And as I told you, in case of PCOD, infertility is very easily treatable. Number 3, if patient is coming to us because of irregular menses. Now, when a patient comes to us because of irregular menses, we can either give her OCPs for 21 days, or what we can do is we can add progesterone, medroxyprogesterone acetate 10 milligrams in the last 5 to 10 days of her cycle. Either of the thing can be done, because the problem here is they have less of progesterone, so it can be treated this way. Now the main thing, if patient is coming to us because of hirsutism, now whenever a patient comes to us because of hirsutism, the first line of management, which is a question, is oral contraceptive pills, combined pills. When you give combined pills to these patients, the estrogen component of the combined pill, it will increase the levels of sex hormone binding globulin. When the levels of sex hormone binding globulin are increased, testosterone, the free testosterone, it will bind to sex hormone binding globulin, and so it will result in decreased free testosterone. So, and if the levels of free testosterone are decreased, that is going to treat hirsutism. Number 2, estrogen component, it will also inhibit 5-alpha reductase enzyme, and this enzyme is essential for conversion of testosterone into its active form, that is dihydrotestosterone. So testosterone will not be converted to dihydrotestosterone. The progesterone component of the oral contraceptive pills, it will decrease luteinizing hormone. In a normal menstrual cycle, estrogen has got a negative feedback on FSH, whereas progesterone has a negative feedback on luteinizing hormone. So this progesterone, when it will decrease luteinizing hormone, I told you luteinizing hormone is responsible for production of androgens from the theca cells. So the levels of androgen will automatically decrease. That is how oral contraceptive pills act. But whenever we are prescribing oral contraceptive pills in case of PCOD, we should be very cautious, because even progesterone themselves have got mild androgenic activity. So we should always choose those pills which contain newer progesterones. And what are the newer progesterones? Newer progesterones are desogestrel, another question, gestodine, norgestimate, or dyspyrenone. These are the progesterones which have newer progesterones which have got very less androgenic activity. And the pills which contain desogestrel, their trade names are Femilon, Novilon, and pill which has got drospirenone, the trade name is Yasmin. Drospirenone, it is a spironolactone derivative, and hence it is also useful in hirsutism and acne. Other option which we can give to these females is that of anti-androgens. Anti-androgens which we can prescribe are spironolactone, cyproterone acetate, flutamide, and finasteride. The problems with anti-androgens are that they have got several side effects, and therefore they are not approved by FDA, and so they are not the first line of drug which should be used in case of hirsutism in PCOD. The third category of drugs which can be used is GnRH analogs. I've already discussed that whenever you are giving GnRH, external GnRH, it leads to down regulation of LH and FSH. If LH and FSH, specifically LH, if that is decreased, the levels of androgens will be decreased, so the problem will be solved. But then, if you are giving GnRH for a very long time, not only will the levels of androgen decrease, because FSH will decrease, the levels of estrogen will also decrease. So females will have menopausal like symptoms like osteoporosis, osteopenia, hot flushes, and therefore GnRH, because of their cost restraints, number one, and because they lead to menopausal like symptoms, if they are used for a very long time, they are not the drug of choice for treating hirsutism in case of PCOD. And the last option for hirsutism is you can go for cosmetic measures like waxing or laser technique. Next, if the patient is coming to us because of insulin resistance, then as you know, the drug of choice is metformin. Metformin, it can also be used if the patient is coming to you with a complaint of obesity. That is all what you need to know in case of PCOD. So this was a deviation from our main topic. The main topic which we were discussing was secondary amenorrhea. In secondary amenorrhea, I was telling you that in compartment 2, the most common cause which you have to remember is polycystic ovarian disease, and the details of which we have discussed. In compartment 3, the common causes are pituitary adenomas. Now the most common pituitary adenoma is a prolactinoma. Now prolactinoma, it can either be a microadenoma or it can be a macroadenoma.